they were trying to get me a passport, and I
Hello, hello. Welcome to How to Relieve Back Pain webinar, hosted by yours truly, Dr. Torrance. Got my fourth year med student finally tuning into this one. She's sitting in the office. She missed it the last one. She was at lunch. So I'm going to share my screen and wait for everybody to trickle in here. If you have any questions, housekeeping tips, put them in the question and answer below. And I will wait for my colleagues to get on. Dr. Pappas is trying to make it. I know Dr. Velastro has been told me that she will not be able to make it today. She has had to get called away. And then Dr. Lieber has promised me he will be here. So we have this squad joining up. Regenix at Newer Generation Orthopedics. We are here in Sarasota, Tampa, St. Pete, and Orlando. Don't accept any substitutes. We are the most experienced in what we do in the state of Florida, by far. Dr. Lieber, you jump on? There he is. I will promote him to panelist. Huh.
Okay, can you hear me?
I can hear you. I need to make you a co-host. 1 second.
Okay.
You can activate. You should be able to activate your video now. All right, making sure that he is on a beach somewhere, aka next to me in the office next door. This is Team Dr. Lieber. We have him on this call. We're waiting for Dr. Pappas, I believe, is going to be able to join us. But the two of us can handle it. We would like to see Dr. Pappas. It's always nice to see him. As I said before you got on, Dr. Lieber, we are Sarasota, Tampa, St. Pete, and Orlando. The most experienced practice in Florida in Regenix, except no substitutes. This is the most experienced practice with the best clinicians. I have a biased opinion. So, all right. You can see the how to relieve back pain on your screen, Dr. Lieber?
Yes, I can.
All right. I'm going to all right. Well, Dr. Lieber, do you want to talk about the anatomy and get this party started? And I'll keep looking for Dr. Pappas. I know he's going to be here shortly. I think he's just getting hung up a little bit.
Yeah, that's fine. If you want to just hit the next slide, please.
Perfect.
All right. Okay, so this webinar is about low back pain and some options for treatment regarding low back pain. There are, I'm sorry, some. Sorry about that. Okay, so the back anatomy is fairly complex. There's a lot of different structures that we need to be aware of that can be pain generators. We have things like the discs, which are between the vertebrae. We have the facet joints, which are in the back of the spine, which get arthritic and are a major source of pain as people get older. The nerves, which come out of the holes, can be under pressure from bulging discs or spurs or narrowing of the canals, gets different kinds of stenosis, and the vertebrae are kind of the main structures of the spine for support. All right, next slide. Lots of different things in the back can cause back pain. In younger people, we tend to see often more disc-related issues as the disc degenerates and weakens over time. It actually hurts less, but it causes a lot more pressure on the facet joints, which are those joints in the back that get arthritic. Those are two very common sources of pain. As I mentioned, pressure on the nerve can cause pain on the leg, and that's sciatica, pinched nerve type of sensation. And then you have ligaments, all sorts of different ligaments here, which can be a source of pain sometimes in the back. They also, when they're weakened or torn, usually weakened in the back, they cause instability, and that can cause pressure on other structures that are more likely to be pain generators. But you can see a large complex of crisscrossing ligaments that we need to be aware of and be able to at times inject if necessary, which is very common in our back procedures. There certainly is a complex multi-layered muscular anatomy, some of which those muscles are for maintaining posture, some are for movement of the vertebrae themselves, and then you have the core, which provides a stable center as you move your extremities around. You need a stable center. So muscles themselves can be a cause of pain, like maybe a strain in a muscle, but often if it's something that persists, it's something more than that. But often we'll see on MRIs that the multifidi, which is the back of the core, can get atrophied, and that creates some instability at a particular segment, which can be a source of pain on other structures. This is an example of a side view of a disc that is herniated into the spinal canal, and then on the view on the right next to I think there's an arrow there. There's a little white spot on the back of that disc that may represent, right below it, that may represent a tear in the back of the disc. We call that an annular tear, or in the MRI, we call that a high intensity zone, HIZ, and that represents a tear which can be, in some people, a major source of ongoing pain for a long period of time. All right. So the conventional approach to back pain has been many different things have been tried over the years. We've got things like physical therapy. What's missing from here is things like manipulation, osteopathic manipulation, chiropractic manipulation, massage, acupuncture, and then a whole series of different things that are being done within the interventional pain and spine community. So specialists in that will do cortisone injections around nerves or related to the joints. They may burn nerves that sense pain from the joints. It's called radiofrequency ablation. There are experts who put in spinal stimulators, which can help with nerve pain that goes down the leg primarily. And then there's surgical options that will fuse areas or take pressure off of areas by removing pieces of bone, for example, putting in hardware in different ways. In some cases, replacing discs, big surgeries, often not the best track record for success, but in the right person, that could be helpful. Narcotics for pain control, NSAIDs, different options for pain, muscle relaxers. Those are conventional treatment approaches. And there are, a small percentage of people we see may need to have back surgery. It's a way smaller percentage than what in reality happens, but there are a subset of people that have may have progressive leg weakness. Their nerve is being compressed so much, and they're getting weaker and more atrophied, or they're losing control of their bowel or bladder. In those situations, they need rapid surgery to correct that. But for chronic pain that's stable or just more, um, it's usually not a great option. Epidural steroid injections, there may be some pros, there are certainly a lot of cons. These are steroid injections that go around the nerves that come out of those canals, and it's usually done for pain related to leg pain from the compressed nerve, not so much for back pain, although it's done sometimes and may or may not be helpful, most of the time not. The pros is it may relieve some inflammation. It could be a short-term solution. The cons are significant and a much longer list than this. It is toxic to cartilage, it's toxic to tendons, it's toxic to bone. It has other systemic effects on your body's immune system, on your body's ability to heal, on memory, on cataracts. Repeated steroid injections can be a serious issue that we see. Radiofrequency ablation, that's the burning of the nerves that come from those joints called the facet joints. Can get some relief in those situations, maybe 6 months of pain relief, maybe more. It comes back, you have to do it repeatedly. In some instances, it can be, a strategy that's helpful. Burning the nerve. One of the cons is that by burning the nerve, there's a higher incidence of developing atrophy in the muscles that are stabilizing the spine right next to the joints there. And so you're sort of creating another problem of spine stability. So we try and stay away from those, and we prefer for patients to do that. But if they have no other choices, it may be worth a try. You want to
jump in real quick?
Yeah.
And then I'll let you pop back in. So what other alternatives do we have to back surgery, back injections, physical therapy, adjustments, stimulators? PRP and bone marrow concentrate. This may be the first time some of these people here on this webinar are actually hearing about these items. And platelet rich plasma, what it does is you harness your body's healing power from your platelets, or bone marrow concentrate, where we get growth factors and cytokines from your bone marrow. And we also get this buzzword stem cells and the mesenchymal stem cells. And we utilize both of these products in our approach to lumbar spine issues, cervical spine issues as well. I wouldn't limit to that, even thoracic spine issues. And this is where we utilize your body's own growth factors and healing cells to really help your back get better, more stable, possibly help some of the arthritis get less symptomatic. And so we promote inflammation temporarily to instill and really recruit your body's immune system to come in and help these areas where there's disc herniations, where there's possibly some bone bruising, some ligamentous instability, to help make sure that the patient's pain and function get better. And we utilize a full body approach, meaning that we're going to inject, Dr. Lieber so eloquently talked about all the anatomic structures. We're going to inject the ligaments, the muscles, the facets in the disc, around the disc, and in the disc in certain circumstances, around the disc in most circumstances, to really help have a functional spinal unit approach to lumbar spine, cervical spine, or thoracic spine issues. And these are some of the injections that we do. Injections like interdiscal injections in the upper left, transforaminal injections where we inject around the disc. An interdiscal injection is injecting into the disc. And this is something that we don't necessarily do all the time, but it does have certain indications. Facet injections, SI joint injections, stabilizing injections like your interspinous ligaments here, or iliolumbar ligaments here. Now, this is a study that was a Regenix study that looked at 13 different firefighters that had low back pain, half with radiating leg pain. And we did this full spine approach. And what we were able to see on some follow-up MRIs was that we could actually see the disc, this is an extruded disc here, actually sucked itself back into the area and actually resolved. And this was something that we can see in certain patients and can help with a lot of pain and issues. In this patient too, we saw some of these discs get much more resolution. This looks like an extrusion, right paracentral extrusion here that resolved on further imaging. And this is more of a degenerative looking lumbar spine that you can see a lot of the inflammation. There's brighter white here, a lot less inflammation. The disc has gotten a little bit smaller. And we can help with the degenerative spine as well as more of the acute disc herniation. And that's something that we can discuss in an evaluation. And this is what we saw afterwards for these 13 firefighters. And we saw that the visual acuity score for pain was 8 down to 0, 6 down to 0, 10 to 0, 6 lost to follow-up, 7 to 0, 4 to 1, 8 to 5, 4 to 0, 9 to 0, 9 to 0. All had very good results. And I'll pass this off to Dr. Lieber to talk about the studies just so he can kind of talk about that. I just want to talk about the Regenix study. And there's multiple studies that show that this approach works. And I'd like for him to kind of talk about these last two.
Yeah, there are many to choose from at this point. When we were first starting to do this, so it was more just our patient population, but now there are quite a few publications. This is an older one now, 2016. This was looking at an approach of injections on 86 patients with chronic low back pain. And in this approach, they were injecting multiple different structures, the disc, in those facet joints that we talked about around the nerve roots, which come out of the holes and stenosis areas, using a platelet type product. And they found, as we would expect, this is not 100% on everybody, but most people will do very well with this. Usually with 1 or 2 treatments is what we find. In this study, they found that 90% of them show excellent response on their pain scores at the 6-month point of the study, which is, I believe, how long the study was. And all 3 of these areas were injected. When we do this, we also inject other structures, some ligaments and muscles as well, which will, we believe, add some stability and contribute to additional benefits. Right, next slide. And this is just another study validating the idea of this kind of multi-target approach, injecting many different structures instead of one. The reason we're bringing that up is because that's not standardly how injection specialists have done things. We have typically injected one structure at a time with cortisone, partially because it's so damaging to tissue, and partially because it's a very scientific way to do things one at a time. Problem is, most of the time there are multiple pain generators, and there's some things that maybe are not a pain generator that are contributing to pain in a different structure, like instability. So we try and do a kind of comprehensive approach and treat the area as one unit, but focusing on the things that we think are causing the most pain. So in this particular study, this was people who had low back pain for greater than 12 weeks, and they've done multiple different types of conservative treatments. And they did a multi-target approach, as I mentioned, and they found in these patients that satisfactions were quite high. Satisfied, very satisfied, that adds up to probably over 80%. Would they repeat the procedure? Also over 80% would do that. And then the Regenix registry data. This is something that was very important to me upon joining Regenix more than 12, 13 years ago, was that the patients are tracked by a team of clinical researchers, and they're followed by these surveys and clinical research tools to see how people are responding over time. We find it to be very important. We hope that our patients also find it to be important and participate. Most people do. And we're finding that the long-term results are very solid. We're seeing reductions in pain and improvements in function in this particular scale in the 70% range approximately on average. And that's a long-term result most of the time. So What can we do? What can't we do? So there's certain things we can do. Certain aspects of the imaging will change in appearance, but a lot of it won't. Once it's degenerated, it doesn't change a lot. Sometimes you see these disc herniations and bulges retract, and you can see the disc health improve. That's a change in the coloring of the disc on an MRI. So we can see that. We can certainly see less pain and more function. Sometimes getting people off of narcotics and NSAIDs is the first step. In other words, sometimes it takes one procedure to get them to the same level of pain that they were on previously with narcotics and NSAIDs. So now they're off the meds, but the same pain levels, and the second procedure is able to get them to a higher level. I see that often, but sometimes just one is enough to get them off and get them a tremendous amount of improvement as well. We don't see changes in the disc height, although I recently saw a paper that was reporting that. So maybe there's some data coming out that can that says that that's a possibility. And we certainly don't see 100% efficacy in every single patient. And that's just the reality of all treatments. This is an example of a change in the coloring I was mentioning in the disc. On the left side is a very dehydrated, degenerated disc. You can see that it's black in appearance. And then as you develop some white in the center of the disc, not the edges, but the center, that means that there's some hydration returning to the disc and some improvement in its health status. This is actually a patient of mine, and I've actually just saw him recently. The top left and bottom left are examples of a very large herniation of a disc that had been there for about 6 to 7 years prior to meeting him, and it had stayed there. Sometimes discs herniation can retract on their own. In his case, it was not retracting. We did 2 platelet procedures on him, one in August and one in November of 2018. And I did not go in the disc in him. I just went around the disc in those cases. And when we did a follow-up MRI in September 2019, we saw a tremendous resolution of that disc bulge and herniation, despite it being present for so long prior. And of course, what we saw with clinically, his severe leg pain had resolved. He's back to me, by the way, because he just had a car accident. That's the reason. So Torrance, this is your territory.
So if you don't like and follow us on social medias, please give us a like and follow. If you enjoyed this, please make sure you jump on. And if you're having some back pain, some neck pain, some cervical pain, those things are all things that we can help with. We have locations in Sarasota, Tampa, St. Pete, and Orlando. And I'd like to take some questions. We've got any? Anybody got some questions here for us?
Yeah, we're going to make it quick. We both have patients ready to go.
Type in the questions in the Q&A box. Oh, I've got a couple here. So, all right. Dr. Lieber, you got that question here in front of you?
I'm not seeing anything popping up on mine. It says,
so I live on the Gulf Coast of Mississippi, and through my chiropractic office, was able to have a regenerative procedure similar to what your clinic offers. I had 3 PRP injections. An article came across when PRP is not enough. Depends on your age group by Centeno. Since I'm nearing 70 and in reasonably good health, I'm wondering if I can realistically anticipate experiencing some improvement to the back pain. I currently have spondylolisthesis, L4 and L5, and arthritis is what caused me to pursue this procedure when it was offered through my chiropractor. So Denise, I'm going to answer this live. We would be happy to jump on a telehealth consult, review all your images, and give you reasonable expectations for what to expect from a procedure with us, and what will be the best choice. So hopefully that answers your questions. Does your age impact the effectiveness of the treatment?
I have them now if you want me to jump in at any point.
Yeah, sure. So does the age impact I'm just going to say, typically, I have a 98-year-old spine patient, Denise. So I'll tell you right now that I've had good results with a 98-year-old patient. So the abilities that we have to concentrate our platelets, that makes a huge difference. And that really just kind of is one of the biggest reasons why we have good success, even at later ages. I don't think a lot of other facilities that do this have that capability. So that's probably one of the biggest issues. So hopefully that answers your question. Dr. Lieber, you want to jump on for if you like stem cells, why not use Wharton's jelly?
Yeah, definitely talk about that. So Wharton's jelly is an umbilical stem cell product, typically very simply, straightforward. The FDA considers that the illegal use of a drug, and anybody using it is using an illegal drug. The products are being sold to doctors when they're tested independently by academic laboratories, do not have living stem cells in them. So that's another problem. The third problem is that there really is very minimal research to support its use at this point in time. So they don't have stem cells, they're illegal to use, they don't have much research behind them. There's a lot of hype, and you'll hear the same story over and over again. You know, your stem cells are too old, you have to use the young stem cells, will be much better. Unfortunately, they don't even have stem cells in those products. How does the FDA allow this to happen? Well, they are going after people. They just and bigger organizations as best as they can, and you can find that information easily at the FDA's website. I'll take another one if you're okay with that.
Sure.
How much diagnostic is done before and after? Well, we certainly, for spines, will need MRIs and sometimes X-rays, and physical exams and history taking, and we need to know the entire context of your medical history as part of our analysis. So it's a standard medical appointment, and we need to have modern imaging to make a determination of how to proceed.
Dr. Let me answer one real quick.
Yep.
Who's had all these modalities, has had a fusion, has had multiple. Yes, we can help with those patients. We do see patients that have had fusions and have had ablations, and they've had everything else, and they're still having back issues, and we have been able to help. So yes, that would be yes to that answer. Just wanted to answer that question. Do you want to answer the experience with PRP stem cells for severe foraminal stenosis?
Yeah, so foraminal stenosis is one of the most common things we're treating. Foraminal stenosis in of itself is the pain is related to the pressure on the nerve that goes down the leg. So I have two of them this afternoon, two patients with that I'm treating. So to some extent, the stenosis is because of a bulging disc, or it can be from a flattened disc creating a space problem for the nerve as it comes out the hole, or it could be from lumpy, bumpy arthritic joint that's creating a space problem for the nerve. So you can get some retraction of those bulges, so that can create some additional space for the nerve. But more importantly is getting the growth factors on that nerve, making that nerve basically more resilient and more tolerant to being able to be under a tight space, and it can function even under those tight quarters. And if you took MRIs of healthy people, you'd find in a certain age range, you'd find a large amount of them will have severe stenosis and not even have any symptoms. So the nerves can function in that state. They just sometimes need some help.
All right. And then do you want to answer do you see any potential for, he clarified autologous fat transfer for spine?
Again, so for spine, I want to get to the PRP not FDA approved question as well. Okay. You could do fat procedures in certain instances. You can't isolate stem cells from fat. That's not legal in the United States, but you can use fat in certain ways. In the spine, we don't find it to be as convenient because the fat itself is very clumpy in the way that we're allowed to use it. You have to use very thick, bigger needles to get it places, and we're dealing with small joints or small spaces. And so we just don't tend to use the fat as much in the spine. And in PRP, why is it not FDA approved? I think that's not an accurate way of asking that question, because FDA, if you read the guidelines, the FDA has guidelines on tissue products, but if they're used in a particular way, like if they're using from the same patient in the same day and minimally manipulated and used for the same purpose that the body would normally use it for, the FDA considers that to be exempt from their guidelines for tissue. So it's an exempt product in terms of if it's used for certain indications like these orthopedic indications that we're using it for.
A great answer. Actually, a patient of mine. Are you aware of any crossover symptoms between lumbar spine pain and sports hernia pain? Do any of your procedures deal specifically with sports hernia pain? You want to answer that?
Yeah, it's fine. I mean, there are two distinct issues, the spine and sports hernia. There can be some conditions in the spine that can mimic a sports hernia pain, but the majority of the time, I don't think that's going to be the case. Sports hernias are sort of a generalized umbrella topic. There are multiple different possible reasons that someone has a sports hernia. Mm-hmm. Very common ones have to do with the adductor tendon in the leg as it crosses over the pubis and goes into the abdominal area. There's a what we call an aponeurosis, or a tissue there that can get weakened and cause pain in that area. But certainly we want to analyze it and see if there's a component of the back that may be contributing in some way, or it would certainly be part of the discussion.
Yep. No, I think that's a great, there's core muscle injuries, there's partial tears of those tendons, those things can contribute to back issues. There's a big pelvic floor push now for instability, and those can all affect sports hernias as well. How long does the pain relief last? This would probably depend on, is this a chronic issue like arthritis that you're dealing with, or is it a herniated disc? And that becomes, part of the evaluation is going to be discussing what issues we're going to, work with and what we're trying to help. Is if it's a chronic degenerative condition, we see patients last forever. We see patients last for a year to 2 years. I don't know if you want to comment differently on that.
It's variable. We have some averages, but I think it's probably a case by case to discuss those things. But oftentimes, once someone gets some relief, it can be long lasting, and long lasting can mean a year to 10 years. I mean, there are times I see patients back 10 years later, and their problem I treated before is still fine. They're just seeing me for something new. All right, so I think we probably need to wrap up here.
Yep.
And appreciate everybody attending. We had
Yep.
a nice attendance here.
Yep.
If you feel like you are interested in a consultation, you have the information in front of you to be able to schedule that, and we'd be happy to evaluate you and consult with you and partner with you and in your journey. We will have the same goals you'd have. Is whatever it is you want to achieve is what we want to try and achieve with you.
Yeah, I got one last late question. PRP versus platelet lysate. More of have nerve root compression radiculopathy in a posterior facet approach, result in PRP entering the posterior disc space in contact, coating the region. How would that approach enable platelet lysate to coat a lateral nerve compression? It'd be nice if you didn't post yourself as anonymous. Sounds like you have some knowledge about this. But yeah, so talking about PRP versus platelet lysate, PRP, platelet rich plasma, is platelet rich plasma. Platelet lysate is a lysed form of platelets that is typically formed by either ultrasonification or how we do it is by freezing the platelets. That causes the cells to be released. So in essence, it's all platelet lysate being injected. So when centrifuging, don't most of the platelet plasma cells burst? That's not true. In centrifuging cells, most cells do not burst. I don't know where that in fact came
Yeah, you
from.
have to do some specialized things in the laboratory to clearly get them to burst, and then we do a filtering process for platelet lysate so that you have just growth factors that are remaining. This sounds like a medical person here. We do transfemoral approaches with the platelet lysate. So you're asking why don't we? And we do. So I think I'm not sure what the
Collateral nerve.
So yeah, that's certainly what we would do.
Yep. All right,
Okay,
Dr.
we got to
Lieber.
run. Patient on the table. So
All right. Thank you, sir. I'll finish up here in Sarasota, Tampa, St. Pete, and Orlando. If you have any questions, let us know. You can email us directly. I have my contact information on here. ron.t@regentampabay.com if you have any questions to follow up after this. Hopefully this was informative. If you have any questions, follow up with us. Thank you so much.
okay, take care, everybody. Bye-bye.